Hello, everyone, and thank you for joining us on this next episode of the Eckhart and Coca Report. Regular listeners of the show may have noticed that my co-host, Dr. Coca, rolls his eyes back whenever I appeal to the idea that voluntary communities are perfectly capable of taking care of the medical needs of their members without the intervention of governments and without the corrupting influence of the government insurance system. Our guest today will make this idea very concrete for us and for our audience. Dale Bellis is the founder of Liberty Healthshare, one of a handful of healthcare cost-sharing ministries that help thousands of families across the United States obtain excellent medical care in an ethical and sustainable fashion. Mr. Bellis began his work in healthcare in 1988 as an administrator with the first cost-sharing group ever begun in modern times. He was instrumental in passing legislation in 11 states exempting cost-sharing from insurance regulations. He also introduced technology and administrative techniques to streamline person-to-person cost sharing. In 2001, he founded a business to administer self-funded healthcare plans for employers. As a third-party administrator, Mr. Bellis developed innovative cost containment strategies for employers. He created the first technology-based audit system for healthcare billing, saving employer plans millions of dollars in unfair charges each year. With experience in both secular healthcare plans and cost-sharing ministries, Mr. Bellis founded Liberty Healthshare in 2012 to provide Americans freedom from insurance and government-mandated health care. Dale Bellis, welcome to the show.
Oh, what a pleasure to be with you, and thank you for the invitation.
It's great to have you. Freedom from insurance and government-mandated healthcare, that sounds absolutely great. Anish will start with the line of questioning about the background. Go ahead, Anish.
So thanks again for coming on. It's really wonderful to have you, and we have a lot of questions. Specifically, we're talking about health sharing ministries, and so just to give a brief little introduction to folks that may be utterly unfamiliar, in a healthcare sharing ministry, members typically follow a common set of religious or ethical beliefs, and contribute a monthly payment to cover qualifying medical expenses of other members. The sharing ministry then match paying members with those who need funds for healthcare costs, or they pool all of the monthly shares and administer payments to members directly. Importantly, the program is not considered an insurance company, and this certainly isn't offered through an insurance company. The program doesn't guarantee or promise your medical bills will be paid or assigned to others for payment. And whether anyone chooses to pay your medical bills is totally voluntary. So as I understand it, the health sharing ministries have really become popular, especially when the Affordable Care Act went into place. And as Michelle's introduction points out, you've had a long history of kind of self-directed, non-third-party based healthcare delivery. How did this all start out? How did folks start thinking about these health sharing ministries?
Well, it really goes back to the traditions, frankly, of America, long before the advent of modern insurance. If you and I lived 100 years ago and had a medical bill, it was our local community who would surround us, support us. Local church, our neighbors, community would come around, help support the family, help pay the bill, and it was a community-based methodology of meeting healthcare costs. Then, of course, with the advent after World War II of the modern insurance movement, particularly in employer-based healthcare, we've come over the last 70, 80 years to believe that there's only one way to meet healthcare costs, and that's through health insurance. And we're just here to say, no, there is another long-standing tradition of mutual aid, of mutual care, of like-minded individuals assisting and caring for one another. And we do that without the help of an insurance company. It comes from our goodwill and our intent to care for and assist another person. And that's really the tradition behind healthcare sharing. Now with the passage of the Affordable Care Act, we've thrown in technology and systems and methodology that makes it much more efficient and can incorporate large volumes and groups of people across America, but we haven't moved away from those roots of person-to-person support and care and engagement to the financial costs of medical expense.
So the history of this is that there were always communities, frequently religious communities that had a kind of shared contract among the community, and so
that's really true. And in fact, the majority of that came from a particular strain of German immigrants that are Mennonites and Amish and Brethren in Christ, the Anabaptist movement, that really have lived that out in a very specific and intentional way. And that's really where the healthcare sharing movement began. And then in 1982, the very first healthcare sharing ministry was launched really as the result of what happened in the life of a pastor here in Northeastern Ohio, that he was on his way to a speaking engagement, and was unfortunately was hit broadside by a drunk driver. His wife was killed. His youngest daughter was killed. His other children were severely injured and in the hospital. People who knew of his ministry, particularly to drug addicts and alcoholics, rallied to his aid, and within 45 days, $50,000 of medical bills was paid in full. And he said, boy, that's the way we ought to be helping each other. And he launched the very first healthcare sharing ministry. That was in 1982. Several others have sprung up since then. And in the course of time, there are about 4 to 5 primary organizations in the U.S. that totally represent about 1 million individuals. We represent about 250,000 of those with Liberty Healthshare, and it's grown and has created quite a strong surge since the passage of the ACA of people joining in on this methodology of meeting healthcare costs.
So talk to me. So it's wonderful. This has existed for a long time. It's a wonderful story. I'll have to roll my eyes less at Michel whenever he talks about these caring communities that care for one another. But there's certainly been an uptick in terms of how much people talk about this since the Affordable Care Act was passed.
Sure.
Talk about why that is and what happened. And you yourself, by the way, the healthcare sharing ministry that you found was started with the ACA, correct? Can you talk a little bit about the healthcare sharing ministry, how it relates to the ACA, and what exactly you founded?
Sure. It really came about, and Michelle mentioned that I launched in the early 2000s a third-party administration company where I administered healthcare benefit plans for employers. And employers that would self-fund. And during that decade, it became painfully obvious to me that there were some deep flaws in the third-party pay system in terms of healthcare. The first being, of course, that when we send our money away to a third party, whether it's an employer plan or an insurance company or the federal government, suddenly it's their money. They begin to decide how to disperse that, and they begin making choices and decisions about the care of my health. And so I lose a great deal of autonomy and oversight regarding my health care. And that what that creates is a distance, a separation, almost an insulation of the individual patient from the care of their health and the costs associated with that care. If somebody else is paying the bill, I don't have very much motivation to be a cost control partner in that process. It becomes more of an attitude of take care of me, of entitlement. And that's a real flaw. And we've seen the rising costs of healthcare just skyrocketing. And I lay the fault of that largely at the feet of the third-party pay system, and that's not even been a part of the conversation by our legislators and policymakers to even address. That's number one. Number two, unfortunately, because it's in the hands of a third party, they're making decisions about my health care when I'm sick. So the only time I go to see a doctor or I'm in the hospital, and unfortunately, the entire economy has been created around the point of service arrangement where the more often I see a physician because I'm ill, that's how they get paid. That's a flaw. That's a sick care system. That's not a health care system. And so those two motivators really caused me to begin to rethink certainly my engagement as a healthcare benefits administrator in healthcare. With the passage of the Affordable Care Act, I was on my way to work one day. The ACA was passing. It hit me like a ton of bricks. There's got to be a way for the average ordinary person to meet healthcare costs without the overwhelming intrusion and control of the federal government. So I began to look for ways to accomplish that, researched it, launched Liberty Healthshare in 2012 in association with one of those healthcare sharing groups that had been in existence since 1995. It was a Mennonite church, frankly, who said, man, we want people to come join us on the basis of our shared values and beliefs, and it's just grown dramatically ever since.
Right. So with the passage of the Affordable Care Act, there was a carve out for health sharing ministries, where health sharing ministries, because they weren't considered insurance plans, did not have to meet many of the somewhat onerous requirements of the regular third party payment system. Right. But so with that, of course, comes a bevy of potential problems. So it's said that, and correct me if I'm wrong about any of this, because I'm learning about this. It's voluntary. It's a cooperative. It's motivated by compassion, the urge to assist another person in need. So that's really what drives it versus an insurance arrangement where there's a contract of indemnity. That's the essential difference. Can you talk about what a contract of indemnity is?
Sure. It's just simply a literal contract in which I enter into that makes a promise to pay based upon my participation in the payment of a premium. And so it details what that insurer will engage in terms of payments for certain losses that I incur, particularly as it relates to my health. So with the ACA passage and the carve-out, as you rightly pointed out, that entire section of the ACA essentially says that members of recognized healthcare sharing ministries are exempt from the requirement to have insurance, number one, and then pay a fine for not having insurance, and also the second half of that, equally as important, exempt from the mandates of the Affordable Care Act. So we get to set our own rules. We call them guidelines among ourselves as members as to the kinds of bills we'll participate in and share in. And so that really gives us the freedom of choice to determine the costs that we will participate and be engaged in paying each other's bills. And it's self-fulfilling. What is so exciting to me about healthcare sharing is that we each one make the commitment of basically in our case, Liberty Healthshare, there are 5 shared beliefs on our website. Folks can check them out that really define the who and what we are and why we exist. And there's really 2 fundamental ones. That is, number one, that we're creatures of God. Our bodies are temples, and we have a moral and spiritual obligation to care for our health, number one. And number 2, we're really placed here on earth to help another person whenever they have a need. And so this is a systematic way to fulfill my convictions about why God's put me here on earth, to help another person, and we fulfill that. So we have a drive and a conscience-based motivation to help assist another person when they have medical expenses. That's the driver behind it.
But that contract of indemnity, it seems like, at least it sounds like something that folks would want, right? Because it is a promise to pay. In your particular case, the reason you're not an insurance company and are able to not be beholden to some of the rules is that there is no guarantee of payment, correct? So whether you receive payment for medical expenses and whether or not this program continues to operate, you're always going to be liable for unpaid bills. Whether anyone chooses to pay your medical bills is a voluntary thing. So
let me draw an analogy about that for a moment.
Yeah, meaning, but is it the case that folks are that'll sound scary to a lot of folks, that if something really bad happens,
absolutely,
I have to rely on the goodwill of others to pay for me. And if for whatever reason the goodwill of others, first of all, there isn't goodwill for me because for whatever reason, or the cost of it is so expensive, there may not be payment. So how do you allay those fears?
It would, based upon the reality of the fact that as a large group, we've successfully met everyone's bills based upon our shared guidelines, we call them, and that kind of voluntary basis of participation gives us the maximum amount of control over the care of our health. We're all self-pay patients, not insured. That means it's my health that I'm focused on. The costs associated with that, it's my dollars at stake. And so our entire community is cost conscious and cost aware because it's our money at stake. The money's coming from my pockets and the pockets of my fellow members. And so there's a sense of obligation that accompanies my choices, realizing that there are people of shared values and beliefs that are going to help pay my bill. And so I want to be aware of those costs, find treatment at the most advisable price, et cetera. And I was going to draw an analogy, if I may. Let's assume for a moment that you went to your local church or community center and joined a group that said, hey, we're all in this community together. We're going to make a commitment to pay each other's medical bills. And you meet regularly, compare notes, talk about the medical system, talk about how to find services at the best price, issues relative to the care of health, etc. And one day, one person stands up, raises their hands and say, hey, I just had a broken arm, and here's my bill. And everyone reaches into their pockets and helps pay that bill. And so that would bicycle around from each member within that group, voluntarily cooperating with one another, but their commitment is to pay each other's bills. And when their bills occur, that same group is there to help meet their costs. We've just added in technology and methodology, systems to accommodate that sort of mindset. And it has succeeded wildly because we have a mutual set of beliefs and values. It's self-fulfilling in that I want my healthcare cared for as well as the others in the community. And we participate every month knowing where our money's going and helping literally to pay another person's bill.
Does this not mean that high ticket items are out of reach? Meaning there are folks that, despite the cleanest living, will have some type of cardiomyopathy and will end up needing a heart transplant.
Absolutely.
So talk to me about how the specifics of that would work. So say a member of your community needs a heart transplant. Heart transplants can be inordinately expensive things. Just the lead up and the work up to getting that. It's not that, I have a bad heart and tomorrow I get a heart transplant and you're admitted and you go home, right? Sometimes these patients are admitted for months and months. Sometimes they need devices before. I mean, the costs to bear seem to be at a level that would break most, relatively smaller type of voluntary payment, schemes. So how does that work? How do you end up paying for that?
Well, number one, it's our money, and so we're really focused on being engaged in those costs. Number two, we're health conscious because we really believe that our bodies are temples. We need to take care of them, and so health conscious people typically have fewer bills and go to the hospital less and recover more quickly. But third, and probably the most important, is that we're just simply agreeing to share those costs on a mutual basis, and in our case, 240,000 individuals across America. And here's how it works. It's two-sided. It's how I participate every month, and then what happens to me if I have a medical bill, and we can talk about both sides of that coin.
Yeah.
But every month, we ask our members to set aside a predetermined share amount. And that's calculated based upon the amount of bills submitted by the members every month and divided equally among the households, whether you're a single, a couple, or a family. Now, the law of large numbers is such that has stayed and does stay the same month after month, just simply because of, again, the law of large numbers. So every month we ask a single to set aside $299. A couple is $399. A family is $529. And that amount of money goes into a secure online account that we call our share box. And through our online technology, that money gets matched to another person who has medical bills. I literally see my money get sent and matched from my account to theirs every month. I get to message them with cheer, with encouragement, with prayer. And so I'm helping to pay the costs of another member every month. And then we cut the check out of the receiving member's account to the doctors and hospitals. And we're using that methodology, paying each other's bills to the extent of $38 million every month. Now, with those numbers, if you have $1 million hospital stay, we can absorb that. A $5 million stay, we can absorb it. A $10 million stay, we can absorb it because of the law of large numbers, the participation, and the basic principle that we've agreed to, that we will share in those costs on an equal mutual basis. If it needs to, because of experience and practice and the members' costs need to be increased in a given month, we'll do that. Or maybe we'll say to our members, that indicates a trend. Costs are going up, and so we need to add an additional $50 going forward. And that has happened one time in our existence, where we've raised what we call share amount by $50 because of increased costs. But that's the mechanism behind paying for and meeting those costs.
Do you also negotiate expenses directly with hospital systems or providers?
Yeah, in a twofold way. As we all know, there's not, unfortunately, a marketplace you and I or anyone else can go to that says, here's what a medical procedure should cost. And so consequently, we've relied on a mechanism or a database. We start with Medicare. Docs and hospitals and healthcare professionals are all familiar with Medicare reimbursement, but that's not enough, frankly. And so we add 20, 30, 40% to that, depending upon the particular procedure. And literally our track record is 97% of all doctors and hospitals and ancillaries, et cetera, accept those payments from our members. The other 3%, we engage in a conversation and negotiate and resolve it on behalf of the member so that 100% of our bills are met. But that methodology in terms of reimbursing healthcare providers and doctors and hospitals represents about a 60-40 kind of discount on actual billed amounts. That is, we're sharing in 40% of what is billed. And so it really indicates that there's a billing issue in American healthcare today, because all we want to do is make sure our providers are reimbursed fairly and reasonably and promptly. That's how we approach that cost.
No, that's right. So that's the whole issue of the list prices being crazy, and but that's really interesting. That so even though you're providing a premium over what Medicare is giving, and you're able to do that, and that's how you get such wide acceptance of your plan to providers. It's something that folks don't understand is such a massive problem with Medicaid. Right? Medicaid is supposed to be the solution to everything, and Medicaid expansion. You know, I can't tell you how many times I am amazed by folks in health policy that think Medicaid is so unbelievable. Like I want to give them a Medicaid card and then go find somebody to take care of them. So that's
again,
great.
That's a part of the government imposition on physicians such as yourselves.
Right.
We value this particular medical service by X, which is far below, in many cases, your capacity to even survive. Right. And so that's why we have relied on Medicare reimbursement tables and added that 40% to it. Because number one, we want to be fair and reasonable. Number two, we want our doctors at our hospitals to thrive and survive.
A couple more specifics, and then I'll get Michelle on. Sorry, just so essentially, there's a premium payment per month. There are deductibles. There are also copays. Correct?
So the first half that I described in terms of the share amount that we participate in, that's the payments that we set aside every month. If I myself have a medical bill, we each as a household have what we call an annual unshared amount. Now, we use that term not to be tongue-in-cheek. We're not insurance, and we don't use insurance terminologies because from the standpoint of the consumer, the participant, we don't want them to confuse us with insurance. So we call it an annual unshared amount. So each family member or each household that has medical costs in a given membership year are responsible for, if you're single, the first $1,000. If you're a couple, it's $1,750. If you're a family, it's $2,250. So we fill up that bucket, whatever expenses we incur in the cost of the year. Once we fill that bucket up, then our members participate together in the costs we experience on an incident basis. Let me just use an example. If I had a heart attack and was in the hospital, I'd be responsible because I'm a family. The first $2,250 I'd pay out of my pocket. Members would then join in and participate up to $1 million for anything associated with that diagnosis. All the doctor visits and hospital stays and surgeries, recovery, medications for that heart attack. If I had kidney stones in that same membership year, it'd be another $1 million. If I had a broken arm, be another $1 million. And that method of meeting costs has proven to be more than adequate for our members.
I see. And what about, and you do have a defined package of benefits in terms of, do the members know, have a clear understanding of what benefits they're getting, meaning whether it be, I don't know, mental health, substance abuse, all of these various different things like
we call them our guidelines.
Okay.
We walk members through, those that are coming to join us in our intake process. We make sure they understand the general outlines of the kinds of bills we participate in. But our guidelines detail those, and we have a constant stream of member education to our participants to make sure they certainly grasp what our sharing guidelines are.
What's the deal with pre-existing conditions? Do folks that are sick to begin with, have chronic illnesses, are they allowed to sign up for health sharing ministries? Do you, as a health sharing ministry, have some type of filter that you can apply? I mean, do you have to accept everyone who applies to your health sharing ministry?
Yeah, that's obviously a big question, particularly under the Affordable Care Act. People have come to expect that their pre-existing costs will be met. We handle it in a couple of different ways, and they're two of them, I mean, both sides of this solution is really important for people who come and join us and consider Liberty HealthShare as a solution for them. The first is our rule of thumb, and we talk people through this because obviously pre-existing conditions are very personal and in many cases, unique to that particular individual. So we're always happy to chat with people about it at no cost to them. But the first year, folks can join us, by the way, any month in the course of the year. So we're not subject to that open enrollment calendar that really is the funnel, if you, as you well know, under the Affordable Care Act for meeting the pre-existing conditions. Folks can't just simply buy insurance throughout the course of the year. They have to do it in that open enrollment period. That's their mechanism for pre-existing. Folks can join us any month in the course of the year. So the general rule of thumb is that if you have a pre-existing condition, it's not eligible for members to share in that first year. Second year and following, we pick up on it, soon phase it in till it's no longer pre-existing. But the second way we deal with pre-existing is probably frankly, the most impactful one I'm very proud of, and that is the vast majority, as you all would know as physicians, of the pre-existing conditions presented are lifestyle-based conditions. High blood pressure, heart disease, type 2 diabetes, certainly obesity, smoking, cholesterol, all of those are lifestyle-based conditions. We welcome folks to come join us, but they do so, and they're required, if they have that kind of a chronic condition responsive to their how they eat and sleep and exercise and live, we assign them a health coach. It costs them an additional $80 a month. We call it Health Track. They come and join us. We share in those pre-existing costs so long as they join Health Track. We assign them a health coach. They set their own prescribed treatment plan and goals. They work towards those objectives. And once they reach them, we celebrate their achievement in our newsletter every month. We graduate, by the way, anywhere from 400 to 600 people every month from Health Track. And then they continue on as members. The $80 drops off. And we're seeing people's lives change, transform, and alter as a result of simply taking responsibility for the care of their health and their chronic condition.
Last question before we get Michelle and all his pent up questions. So is that the mechanism? So we talk a lot about the Affordable Care Act and insurance general, not just the Affordable Care Act, about this difference between what's called community rating and risk rating when you're enrolling members. Community rating is where you don't consider pre-existing conditions that the patient has when setting premium amounts. Risk rating is setting premium amounts and costs to the patient relative to what they have. So if you're a smoker, have diabetes, have coronary disease, in a risk rating model, your insurance premiums will be higher. In a community rating model, the third party and payer, the insurer, does not typically, cannot ask these questions and therefore must set premiums being blind to that. This $80 additional that you pay, that you do for certain chronic conditions, is that how you?
No, that's a pass through for the cost of the health coach.
Okay. So yeah. Do you have higher?
We don't rate individuals based on risk as they come to us, because it's a mutual share amount. They just simply join the community, and as costs go up, if they do, as a group, we address those expenses. So, we're not risk rating an individual. No one pays additional because of their particular condition. We never drop anyone, regardless of how sick they become. And so the individual household is not evaluated as to the cost that they present to the group. It is simply a mutual expense that we incur or address every month from the entire 240,000 lives.
So they're not folks that you turn away because they're too sick. You don't say that this is not right for you. You need to do something else. Is that clear, or is that?
We do not turn people away because of the pre-existing conditions that they bring with them. They evaluate in many cases whether it's suitable for them, particularly because of that 1 year period where we're not sharing in those costs.
Right.
So that may be onerous for them, and they wouldn't participate for that reason. Or if it's not lifestyle based, someone comes to us with Lou Gehrig's disease, or some severe health condition that's expensive and costly, may not be suitable for them because of that first year. But we do discover in many instances the costs associated with pre-existings in that first year are literally less impactful to them financially because of what they've been used to paying or asked to pay in the secular healthcare arena. I'll just give you an example. Young couple came to us. They live in Washington, D.C. Jen, and his name's Tripp. That's an interesting name. But Jen and Tripp in Washington, D.C., they were paying $2,600 a month for their healthcare plan. They came and joined us, $529 for them and their 2 children. Their 2 children had pre-existing conditions that was costing them $800 a month. They gladly, gladly spent the $800 in that first year because it was such a dramatic savings overall. And in a year, it'll no longer be a pre-existing. So that happens frequently.
It's important to highlight the fact that all payers need some type of mechanism to prevent gaming of the system. So where you don't get any insurance until something bad happens, then you sign up for an insurance plan, right?
Let me pick it up here, because that's going to be on my
okay, good
part of the question that I want to ask. So Dale, I want to go back to something that you mentioned earlier. Or 2 key aspects. One is the shared beliefs among the members. These values that they're going to take care of themselves and take care of one another.
Yes.
And the other one is the law of large numbers that allows you to sort of survive. Now, there can be a little bit of a tension, the way I see it, between those 2 things. The way I think about it is this: when the ACA was passed and they had a carve out for cost sharing ministries, they specified, if I understand it correctly, that only certain existing cost-sharing ministries that had been around for more than 20 years, right, since before 2000 or before 1999, right, qualified.
December 31st, 1999.
Right, that they qualified for this exemption, for being exempt from the Obamacare mandate and the fine, and that, if I seemed to have caused a rush of interest among a lot of folks into towards the health, the cost sharing ministries, right? And the numbers have sort of swelled, right? Has it been? You've had a lot of interest in the cost sharing ministries with the passage of the Affordable Care Act.
The statistic that we've been able to collect is that in 2010, with the passage of the Affordable Care Act, there were about 200,000 individuals engaged with healthcare sharing ministries in 2010. It has grown substantially over the last intervening years, till now there's more than 1 million that are participating in cost-sharing organizations. And as I mentioned, we represent 250,000 of those. And so the other sharing ministries, there are primarily 5 in the U.S. that are of substance and size. There are plenty of small little pockets, local churches that engage in this particular model of meeting costs. Over 180, because of the requirements of the ACA to submit a registration that you were a healthcare sharing ministry, over 180 have registered with CMS and received their letter of recognition as a healthcare sharing ministry. But again, only 5 of that 180 are really of any sort of size and substance.
I see. That's interesting. I didn't know that. I thought it was just primarily those, 4 or 5. And but again, my question is that is it challenging a little bit when a cost sharing ministry grows? Then you have the benefit of the large numbers, but at the same time, perhaps you lose the sort of the personal knowledge of one another, right? I mean, if you're a small church or a small community and everybody knows each other, it's a little bit easier to gauge the sincerity of the members, and whether to what extent they share those values precisely, or what Anish was alluding to. Are they joining primarily because of these? There's nothing wrong with joining because there's a calculus, right? There's a savings. You can save money, of course. I mean, that's very important. But at the same time, if it's the primary driver, and if people join because they view it primarily as something that's going to save them money over what they would have to pay, in premiums, then you may be getting people who. How do you deal with that? With this, or you think that the large numbers essentially compensate for the fact that some people may be joining that may not exactly share the values?
Yeah, we don't try to police
right
an individual's adherence.
It'd be impossible,
to
right?
Values and beliefs. We want to treat each other as adults. And so we come to this with the belief and expectation that we will all join in because we really do believe in and adhere to those lifestyles and beliefs. And every member who enrolls signs off on that. Now, is it possible that someone would join us and not do so sincerely? I'm presuming by the very reality of human nature, that's the case. That's not been a large issue for us.
Okay, so in other words, you
like-minded people, and when folks look at us as a cheap alternative to insurance and suddenly realize that this is based upon our closely held values and beliefs and what we do together as a community, and their dollars are being not sent, not dropping into a company black hole somewhere. They know where their money's going every month. Their dollars are going to another person. And they know that it's going to Michelle. And you disclose as the receiving member to the extent that you feel comfortable as to what your condition is or what your need is. And I get to send you a message of cheer, of encouragement. Michelle, I'm praying for you. I hope you get better. That kind of environment tends to simply eliminate those who don't have identification with that sort of method and methodology. And we use modern technology, the internet, our own technology that we've written and developed to really enhance and support and put tools in the hands of our members to enhance that sense of community. But that's the sort of folks that we attract, and it becomes a self-filtering system. Okay.
And in other words, you haven't seen in the after. I mean, if you were, well, maybe for you, you founded Liberty Healthshare with the recently at the beginning of the ACA. But I was wondering if somebody who had a cost sharing ministry for 20 years before, if they saw a change in their member makeup in the aftermath of the ACA. And from what you're telling me, there doesn't seem to be any substantial difference. That's
not substantial difference.
Okay.
No.
Okay. Are there? So this is news to me that there's 180 registered cost-sharing ministries. As far as you know, does that span a wide spectrum of faith and religions? I mean, they're primarily going to be religious groups or have some kind of religious affiliation. What's your sense of that?
Of the 5 largest healthcare sharing ministries that are cross-denominational, the vast majority of those others who are registered as a healthcare sharing ministry are local churches, Mennonites, Amish, German Baptist, etc. Largely those that come from the Anabaptist tradition. And so consequently, that is not as representative of the religious community as those 5 that are trans-denominational.
Right. And
frankly, in our case, we don't even ask what church you attend.
That's right. So that's what I wanted to.
We don't intrude on individual faith choices or what your doctrinal statement is or what your beliefs are, and we don't check up on that. We just simply say, here's our shared beliefs. Can you come and join us on the basis of these 5 values and shared beliefs? And that's how we've structured our healthcare sharing.
Yeah, that's right. So I thought it was an important point to make that sort of it's inclusive in a way. I mean, there's a general principle or some general principles, but otherwise it's not really restrictive in that sense. They can be, so long as people share those general beliefs, then they're welcome to join.
Now, we are unabashedly Christian in our origin. We base our sharing principles on our Christian values. But we don't ask whether an individual is a Christian. So long as you're willing to share on the basis of these Christian values, you're welcome. And so consequently, we have Jewish participants.
That's right.
We have Hindus.
Right.
We have Muslims.
Right.
And of course, the vast majority of our members are Christian. But they do so recognizing and understanding we're a Christian organization. But those principles are also reflective of multiple religious traditions across the board and through the centuries. And so we believe that represents a unification of men and women across America that otherwise would not be there. It really does bring out the best values, the best response, the best sorts of traditions that we want to foster in our nation. Generosity, care, love, support for one another. And so that's what I see our contribution to the national character that we're encouraging and supporting and reinforcing.
That's absolutely terrific. For full disclosure, my family and I, we're members of a cost sharing ministry. We've been members for the last 5 or 6 years, and it's, I can't imagine any other way. I mean, it's really the ethical and responsible way of helping one another with healthcare costs. I want to ask you a little bit about the cost sharing ministry in an environment where third-party payments, the insurance is so predominant and perhaps increasing if the government is going to expand or they're trying to expand health insurance, to as much as they can. As you alluded to at the beginning, really, I mean, health insurance is the reason why healthcare is so expensive, or at least, one of the major reasons why healthcare is so expensive. And it's expensive for people who don't have health insurance. It makes it expensive for other people who don't have health insurance. It makes it expensive even for people who do have health insurance because the copays are increasing. Whatever they have to pay is getting more and more, and they don't have control of their health care the way they ought to have. What are you guys thinking, when you have your board meetings and whatnot about what's going on in healthcare, and if it's a threat that insurance is going to, if it gets expanded, is that a threat, or how are you dealing with that? Or you mentioned that you have some kind of, on a month-to-month basis, you keep track of the costs, right, the expenditures for the group, sure. And you see if it goes up, then you have to increase the members' contributions on a monthly basis. But
I believe we have a valuable voice in the discussion of our national conversation regarding healthcare and how to control costs. And that model is being heard and listened to by policymakers and legislators as they grapple with what's the best path forward. And I just have to say, I've had opportunity to engage in those conversations. with both policymakers and legislators about the path forward. And in my estimation, the amount of discussion going on right now for those hoping or wishing for some kind of socialistic medicine solution for Americans. The universal or Medicare for all is the kind of active phrase. Is an opportunity for us as a nation to really examine what are the fundamental underlying value systems that produce the best results. And our voice has been heard. We'll continue to raise it. And I don't know if America will ever institute, a government-controlled and paid-for healthcare system. But if it ever does, believe me, we will be raising our voice loud and clear, as we did as a group of ministries in 2010. That here's a proven process for meeting healthcare that empowers and frees the individual consumer to control costs. Don't shut that down, and enable us to continue that tradition. So that would certainly be my belief and hope.
The line of attack they're going to take, though, is going to say that health sharing ministries disproportionately draw healthy people to the pool, and so thus hurt the broader insurance market.
We've already heard that.
Right. So whether it be
faulty premise.
I mean, you don't think they have a point? I mean, no. For instance, you yourself said that
sorry, I don't accept the premise.
No, that's okay. So you yourself just said that, you have, for folks who have pre-existing conditions, who have Lou Gehrig's and stuff, and they may have an owner's burden that first year, because they're going to have to cover a significantly larger percentage of the cost or whatnot. That automatically will make for a healthier pool. Wouldn't you say? So automatically you're instituting things that are going to draw healthier people to your particular pool. So go ahead, but tell me why.
My argument, honestly, and I love the challenge of the statement, because it addresses the failure of our nation to ground our healthcare system in a baseline value. If we're not values-based as a nation and as a country, and instead we foster this attitude that says I'm owed it, I'm somehow in line to receive this benefit for no other reason than I happen to draw air, that's a flaw. It's a problem. We as a nation have to take responsibility for the care of our health. That's bottom line. And so what we attract, you're exactly right, are health conscious people, not healthy, but health conscious. Folks who are willing to assume and take on the responsibility for watching out over and living their lives in ways that promote health. Now, health conscious people tend to have fewer bills. And the compassion that we express as a group helps meet the pre-existing costs of individuals regularly. We raise money on the side, apart from our monthly share amount, to help pay for pre-existing costs of individuals that need it. That's an expression of our care and concern for one another. And there is a simple methodology for meeting the catastrophic costs of pre-existing in our nation as a population that would be easily accomplished apart from those who, for no fault of their own, have healthcare expenses and costs. We can easily, no one wants to withdraw that safety net from people and their lives. And yet we believe that a significant part of those pre-existing costs just simply would be allayed if folks take responsibility for their health.
Of course, and that has to be understood by the fact that if the demand for healthcare services starts to drop, then prices will necessarily follow and drop. Whereas in the insurance-based system, where people are entitled, or feel this sense of entitlement, many healthy people end up using a lot more healthcare resources than they would otherwise, and that drives the prices up because they utilize more. Doctors are able to charge more, hospitals are able to charge more, and so forth.
And I submit to you that one of the reasons why that's true, Michelle, is there's nothing in our existing system that puts the power in the hands of the consumer. It's not their money.
That's right.
And if it's not their money, there's no motivation on their part to control their costs, to be engaged, to be health conscious and health focused, because it's not their money.
Right.
If we simply do nothing more than reverse the flow of the dollars so that the individual consumer has within their hands the ability to make choices and healthcare and engage in their healthcare, and it impacts their pocket, we would see transformation across America in terms of costs, because it's just a natural motivator. If it's affecting me in my pocket, then I'm going to choose differently.
I certainly agree. So in the time that we have left, I want to engage you, Dale, a little bit on to comment on something that we've talked a lot on this podcast. There's a very hopeful trend among doctors of people who say no to the insurance programs and start to engage in a direct relationship with patients, the direct care movement, whether it's the direct primary care movement or the movement of the surgery centers that offer surgeries on a cash basis for a transparent price. And it seems that that movement is very much aligned. I mean, the interests of that movement are aligned with those of cost-sharing ministries and the members of cost-sharing ministries.
I love direct primary care.
Right.
I think it's going to be a transformative movement, I believe.
Yes. So do you, I thought you'd be aware of it. Does your organization, I mean, I don't want to say promote the direct care, but maybe you do, or how do you take advantage of that movement, which I think is also a very healthy movement? To take advantage of it, I think it would be helpful for the members to be aware of that direct care movement.
We inform our members about that, absolutely, and make a consistent, regular educational thrust to encourage our members to find either a primary care physician or a direct primary care treatment center to enroll in and participate, particularly for direct primary care. We encourage our members to do so and make that connection with a direct primary care practice. And we reinforce it by sharing or participating in some of the add-on costs associated with that access fee. So that if they're accessing a DPC, let's assume it's a family, $100, and they're participating in that, we want to reinforce and encourage that based upon the character. We have a sliding scale that will share in those access costs, and based upon how the practice itself is created and set up. We always believe that the relationship is between the patient and their doctor. We don't intrude on that relationship with the patient and the DPC practice, but based upon how that DPC organizes and structures its practice to reduce costs and provide added services to its members, will reimburse that member up to $75 or 75% of their costs for enrolling with that DPC. That's largely because we are the only healthcare sharing ministry that I know of that shares in preventative wellness care. And we encourage our members to get that annual checkup, to engage in preventative care, and even naturopathic care if they so choose. And so for that reason, we really want to encourage people to take initiative regarding the care of their health, and based on all the statistics and reports and insight from our own data and nationally, DPC members and patients certainly maintain costs and pay attention to health.
Great. Anish, any final question?
No, I was going to say, when you folks were talking about the Christian roots of healthcare sharing ministries, that as a Hindu, it's easy to be totally okay with this, because Hindus, for reasons of spirituality and I guess the number of gods we've accepted, have always been very accepting of other faiths, and have always loved the message of Jesus. So I know when I was doing a little bit of research for this podcast, that a frequent beautiful verse that is frequently quoted is one that the Apostle Paul wrote, which is bear one another's burdens and thus fulfill the law of Christ. It's a wonderful message that any good Hindu would endorse as well. So,
well, thank you for that, Anish, because we really do take that seriously as Jesus followers, to bear the burdens of others and fulfill his law, which was the law of love. And Jesus went on to say, what does it mean to love your neighbor? The story of the Good Samaritan is a classic example that we're here on earth to help another, regardless of what their identification, their religious affiliation, what their role in life is. We're here to be an outreach of love to help another person when they're in need.
Right.
So that's what drives and motivates us.
So
that's why we welcome those of other faiths to come and join us.
Yeah, so we may end up in very different places in the afterlife because of our beliefs, but at least while we're on earth, we may love each other.
Let's do it.
Amen. Dale, this is terrific. It's a very, very hopeful trend. I've been talking about it on my blog for a number of years. We haven't talked much about it, as much about it on our podcast, so I'm really glad for the opportunity to present this piece of information. I mean, about cost-sharing ministries. It's really just a fantastic development.
Well, one final thing. It ought to be a part of a person's assessment of how to meet healthcare costs. It's simply one of those active alternatives for meeting healthcare expenses, and it just really needs to be a part of the
Can I ask both of you your opinion on are you? Is it okay to have a multi-tier system? Meaning, is it all right to have? Would it be all right to have some type of national insurance plan that folks could sign up for, as well as that was taxpayer funded, and the usual third-party stuff, and also have something like health sharing ministries, or do you think it has to be a one or the other?
Well, if my perspective is, if the power is in the control of the consumer, the issues, the problems, the high costs, the access issues will all be addressed if it's in the power, if it's in the hands of the consumer. Doubling down, if the third-party pay system as it exists today is problematic, why would we ever want to double down to the extent that it's the government who is the ultimate third-party payer? I just shudder at that prospect and think that it just flies into the face of not only the traditions we've experienced in America, but just the practical consideration of how do we address economic issues in the most beneficial fashion. My answer to that is give more power to the consumer.
I agree. And Anish, I think this idea that you could have a coexistence between a government-run system and a private system, the government system is generally always predatory, is going to try to expand because it's not there. It's there primarily for control reasons, not for reasons of shared values. And it doesn't tolerate the competition of the private system. And it will try to expand and so forth. So I'm hoping now that there's a little breach and the healthcare cost-sharing ministries have a foot in the door, can continue to expand and do a lot of good. I wish the law would loosen up a little bit, right, to allow more organizations that are based on the same model to to develop. There might be room for that and continue to expand the idea.
Well, I would certainly encourage that. Competition and choices just simply give more opportunities for people.
Right. Dale, that's great. Where can people follow you? And at least, certainly, your we'll have a show note link to your health sharing ministry, Liberty Shares.
Yeah, libertyhealthshare.org is our website. libertyhealthshare.org. That's the best place to go. I always encourage people to get what we call our free an information packet. It's free, but we call it our decision guide. You can ask for it right there on the homepage, give your name and email address, and it gets sent electronically to your email. And so that's our decision guide, just chock full of explanation and information about Liberty HealthShare. I encourage people to give us a call. We love to chat it through with people. And in fact, a lot of times people just like to do that very thing, talk it through. We have an entire group of folks here at our home office that love to field those calls. So easy number to remember, toll free. And it's 585-58 Let me say it again. I apologize. 855-58 Liberty, and it's there on our homepage. Or peruse the pages of the website, but libertyhealthshare.org is the place to go.
Terrific. Dale, thank you so much for your time.
My pleasure. Thank you, gentlemen, for the invitation. God bless.